this is the last video. It's going to be about just the rest of the stuff. First one is going to be VTAC. VTAC can be pulseless or with a pulse. If they've got a pulse, depending on how stable they are, there's a few different things you can do. If they are stable, you can give them, I want to say amiodarone and lidocaine? Yeah, it does say that. So amiodarone and lidocaine IV to try to get it back into rhythm. But these patients, they're only going to be able to handle this for a certain amount of time. It's kind of the same thing with SVT too. Like SVT, if you get it towards the beginning, then they haven't decompensated yet. You can, try the vagal maneuver and then try adenosine. Or wait, there's something in the middle there. Nope, that's actually it. Oh, and then cardioversion. Adenosine is the middle. I'm an idiot. I'm so tired. But anyway, if they have a pulse and they're relatively stable, get pads on them because they could decompensate very quickly, and then you'll treat it with IV amiodarone or lidocaine. If you have a patient in the clinic that has this, like, get your AED, call 911, slap some pads on him and pray because it's bad. And so that is a monomorphic VTAC because they all kind of look the same. I wanted these papers to have examples of the other kind, but I don't think they do because that's another monomorphic. Even though it kind of goes up, that's probably just respirations. So that's not great. So I pulled this up on my phone, and you have to kind of look at it at a weird angle. Let me get it. There you go. You can kind of see it. So the top one is the monomorphic VTAC. See how it's the same over and over again? And then the second one is it's polymorphic. It looks kind of similar to VFib, but you'll notice that it's really pointy, but the points are never the same. So that's polymorphic VTAC. They're less likely to have a pulse with that one, but they could. And then this bottom one is called torsades, and this is treated with magnesium IV. You may have to shock it too, but you want to have some magnesium around because that's the only thing that'll really fix this. And reason it's called torsades, golly, there we go. Torsades, maybe in French or something, means twisty. And if you look at it, it kind of looks like if you were to have like a ribbon and then you twisted it, and it's in different, like you're looking at it from different views, so it'll go really wide and then narrow and wide and narrow, just kind of over and over again, like a DNA helix kind of. So that is torsades. And there's the old VFib. It can be coarse or fine. I've never seen anybody have a pulse with this, basically because they're not having any sort of regular beating to make a pulse happen. It's just going blah, blah, blah. VFib is just completely disorganized, and the ventricle's last-ditch effort to try to get something going. This is normally pulseless, and you're going to do CPR and shock, and then follow the protocol, like epi, amiodarone, all that crap. There's a couple more examples of it. See, this one, you could mistake this one for a VTAC, except for, like, that kind of looks organized, but that crap in the middle there doesn't. So that's what you're looking for, is just really crappity crap. And then the coarse will normally be bigger like this, and fine will be a little bit, like the amplitude will be smaller and smaller and smaller. And fine can get really small. Like, you can think that it's asystole until you get really close, and it'll actually look like that. So if you've got that, that's still VFib and it's still shockable. If you get asystole, not shockable, just do CPR and start the epi pushes. And that's it, right? Oh, look, it did have examples of it. There's some polymorphic VTAC. That's torsades, because see how it's getting fat and skinny and fat and skinny. And what's down here? That looks like it's probably part of torsades too. And look, this has like a, this could have been an R on T or something like that. They think, that guy, the football player that got hit in the chest and he coded on the field? His would have looked kind of similar to this because he was having a normal beat, and then he got a pow in the chest, and it shot him into a deadly rhythm, is the theory. Idioventricular is its own little thing that is like so hard. Like you just never see it. Like this patient is almost dead. This is what you'll see sometimes, like when you've gotten a pulse back and then it's kind of slowing down and slowing down and slowing down and they're about to go all the way out again. You'll see something like this. And it's going to have super wide QRSs and it's going to be really slow. And there's like no electrolyte. It's junctional. Junctional is not any. I kind of think of it like this. Hold on. Like, there's the heart again, but I'm just going to do the atria and the ventricles. And all those atrial beats we talked about at first were from kind of there. And then the junction is the AV node, and it's kind of right here. The SA node's up here. So if it comes from this area, it's normally junctional. So atrial 60 to 100 is normal. Junctional 40 to 60 is normal. And then the idioventricular are normally 20 to 40 because that's like the very bottom of the lane. Oh, my pin's going out. When the electrical signal is coming down, it should come up here. Can you see that? Yeah. It should start up here and woo, and then go around like we talked about. This is like, all of this has failed. And there's a little guy right here at the bottom of the bundle of the His, or where it starts to divide off into the right and left bundle branch. It's given its last ditch effort to try to do something. So that's why it's so slow and so wide. It's because the ventricle is just saying, help me. You can use atropine on that. Oh yeah, and then here's pacing. This is an AV pacing, and you can tell because there are two pacer spikes. So it paces the atrium, and then it paces the ventricle, and then atrium and the ventricle, and then you set that at a rate. So the doctor, they have it preset, like if the person's natural heart rhythm decreases below 60, it'll come in and fill all those in. So if they're AV, that means they've got two wires, one going to the atrium, one going to the ventricle. You can also have another kind where it's called a bi-V, and it goes to, one wire goes to this side of the ventricle and one goes to this side of the ventricle. That's for more severe issues. But anyway, you'll see this one a lot, and then you could also have just A-paced. Let's see. Yeah, this is just A-paced. Because see, the pacer spike is right there, but there's no spike to make the ventricle go. It goes on its own. So this is like a SA node dysfunction. And then you can also just have V-pace, which is when you've got an electrical signal that's correct from the P wave, but does not get conducted down to the ventricle. So it just kind of stops. So you'll have a normal P wave and then a pacer spike, which, let's see. This one is actually a junctional rhythm because there's no P wave. They're just having, so this person needs an upgrade. They don't have P waves. Can you see that? Yeah. Oh golly, you guys. So any questions, you can post them and I'll try to answer them. But I really like cardiology, and I've been doing all this stuff for a long time. So that was like everything. There's all these little idiosyncrasies that are different, but that's everything that you could possibly ever be asked on a test. But really the ones that I think will most likely be on there would be like identifying some sort of sinus rhythm, normal versus Brady versus tachy. I think that would probably be there. There may be an AFib or an A-flutter. By the way, you can also have like a combo, and they call it AFib flutter, and it'll be like ziggy, 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 and then a QRS, and then ziggy, 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 QRS, and then you'll be like boom, 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 QRS. And so it'll kind of go back and forth between the fib and the flutter. And then one of the deadly rhythms, well, the heart blocks. I think there'll probably be a heart block you need to know. And remember, there's type 1 is just like equidistance, that's a little too long. Type 2, winky buck. Let's see, second degree, so this will be first degree. Not type 1. First degree, P wave, too long, QRS. Second degree, type 1, which is winky box, is the P wave that looks normal, and then it gets a little too far away, and then it gets a little further away, and then drops a beat. So that's winky box. And then there's type 2, second degree, Mobits. That they try to confuse you with that, but these are both called Mobits and they're second degree, but there's different kinds. And this is the one it looks kind of regular. Boop, boop, and then it'll just drop a beat for no reason, and it could drop more than one. Boop, but it has to be regular, and mine aren't. So, and then it'll pick back up and QRS again. But this distance should be the same over and over again. The P to the QRS. Boop, boop, boop. And then type 3 is when you've got, and I'm going to draw this kind of in a funky way, you've got P waves that are pretty regular. So let's say that's beating at like 60 beats a minute. And then the QRS is like, so, that one kind of got out of control. But they'll be regular as well. But they do not coordinate. So like this one would probably look a little funky. Like in real life, it would kind of look like that because the P wave is hiding underneath that QRS. Okay. And so yeah, one of the heart blocks would be my guess, and then like a VTAC versus a VFib. And the VTAC can be broken down into monophasic and polyphasic, or torsades, really. Okay. Yay! I think that's pretty much it. Oh, SVT could be there. SVT is the really fast. You don't normally see the P waves because it's too fast to see them, pick them out. And it's coming from somewhere else in the atria. The original beat. It's not coming from the SA node. It's coming from somewhere kind of near it in the atria. Yay! I hope this was helpful, guys. Thanks. Bye.